Okay, welcome back. It's my pleasure to introduce our keynote speaker, Jeffrey Driver. And Jeff is currently president of the Stanford University Risk Foundation. Jeff has a credential a mile long in this space. He has been a former president of the American Society of Healthcare Risk Managers. He has 25 years experience in numerous different organizations as a leader in risk management, patient safety, and regulatory advocacy. I first knew Jeff when he was at Beth Israel Deaconess Medical Center in that position before he moved on to Stanford, where his official title is Chief Executive Officer of Stanford University Medical Network Risk Authority and the Chief Risk Officer of Stanford University Medical Center. Jeff has done some really groundbreaking work as the Pearl program has been launched at Stanford University under his guidance, and we look forward to hearing about those remarks from Jeff. Welcome.
Okay, good morning to you all, and it's great to be back in Boston. I actually never left. I have a house in Newburyport, so I get back here all the time. But I did watch with really a sense of sadness for what happened here and what you're going through. But as I know Boston and this region, these are tough people here, and you're all coming back. You did just a fantastic job, and everybody's talking about it from coast to coast and around the world. So what I'll do for the next 45 minutes, or maybe we'll make it 40, I think we're a little bit behind. I'm going to talk to you about Pearl, which is our West Coast version of the work that you're doing. We've been working on this since 2007, so I'm going to talk about our journey. We're now at that stage where we're evolving the program and taking it to the next level. So you'll see some more advanced thinking, thinking that would probably make you very nervous, but over time, maybe this can show you where you may evolve to eventually. So here are our learning objectives. We'll talk about our program and the history of it, our very specific design. I want to get to those enhancements. We have some outcomes that we will share. These outcomes are measured by an independent actuary. By no means are they as extensive as University of Michigan because we are in the process of data collection. I think in Michelle's kind of setup here, we are a medium-sized institution. I like to think of ourselves as an incubator. We have about 1,000 beds, 2 hospitals, 2,500 physicians, and a growing network with 2 captive insurance companies. And then finally, we'll talk a little bit about the new Medicare rules and how that impacts programs like the ones that you are contemplating or are in, as well as Pearl. So first of all, what is Pearl? You may classically think as a compensation model, but it actually goes way beyond that. When we talk about loss, which is the L in Pearl, we're talking about all kinds of loss, whether it's the loss of confidence of a physician or a nurse, or even leaving the practice, or the loss of confidence that a patient has in their care team, or the trust that they have in their care team. It goes well beyond compensation. It includes all forms of loss. Like care, we came up with Pearl because we needed to sell something internally, and you're in that process now of selling. We've moved through that. In 2007, we sort of started the process with what I would call a selective practice, and that's a good place to start because you want to get your feet wet, kind of put your toes in, and maybe you're up to your ankles before you have a full immersion. So for us, we began by just looking at the failure of risk management, and we all know about this. It's been well documented that we could do a whole lot better in the area of patient safety. This is a book, this is our Bible back at Stanford. It's written by Douglas Hubbard. It's called The Failure of Risk Management. But more importantly are the words on the bottom. They actually should be the large letters, why it's broken and how to fix it. And this has really driven our strategy with Pearl being really one part of an overall strategy that we call VDERM, which is Value-Driven Enterprise Risk Management. Simply stated, that is ISO 31000 for the risk managers in the room. You know ISO 31000, 5-step risk process. We then infuse that with decision analytics from the School of Engineering at Stanford, and we get a process that looks like this. So Pearl just really is one part of an overall risk management and patient safety strategy. So I told you we start with a discrete and selective practice. Shortly after I left BIDMC, went to Stanford and was interested in this space. So we started playing around with this. The interesting thing is we had successes and we had failures. We had some big failures. And so we had mixed feelings about moving into this space, but we continued to plug away. And then we looked at pioneering programs, we studied them. We did a full SWOT. At the time, it was called full disclosure. I always have hated those words. Is there anything less than full disclosure? Are you going to come out and say, we're going to do a partial disclosure program? I don't know. So I'm glad we have abandoned that language and we're moving on to something more healthy. So we manned up and we launched a formal program in 2007. I brokered with the board that we would do this in a very careful way. Two things that we did is we asked an independent actuary to watch over our shoulder at all times. Because of course, what are you worried about? You're worried about everything just taking off from you, and what good will that do? That would be a failed program immediately. Second thing we did is we partnered up with Michelle and Tom Gallagher, and a research component of this is very important. I just learned today that we struggle with our IRB back at Stanford, no surprise, but we will make it through that. We are collecting about 15 different variables. I'll share that with you in just a little bit. More importantly, recently, because of our success, and we have trimmed millions off of the premiums for our hospitals and our School of Medicine, our faculty physicians, we have taken the program really to a level that I don't think I've seen anywhere else. We not only invite referrals from our clinicians, but we are quite public with our patients. They can enter the program self-initiated through a patient portal, which lives on the websites of all hospitals that we insure or will insure. And I'm going to show you what that looks like. So we, of course, are entering a somewhat controversial, less controversial now. These were fighting words. This should look familiar to you, Michelle. This is a paper that came out years ago, and it was really one of the triggers for us. The words an improbable risk management strategy really, those were fighting words for me. And so I looked at this study and said, well, you know, they make some good points here, but let's study this more. And this is well within the research mission of Stanford. More recently, however, there's some more enlightened papers coming out, really kind of struggling with what we all struggle in these programs. You know, offers on their own, it sounds great, but it's really a difficult road to follow. And this is kind of where we are now, and I want to share with you. So we describe our program as once optimistic and cautious. That was the beginning. We are now convinced, but we continue to be careful. Heavily influenced by Stanford's research mission. So we have to understand that, first of all, Stanford is a unique organization. It's not a closed model, it is a quasi-open model in that we have community physicians coming in. And we do have the situation where we have two separate carriers going two separate ways. We do our own thing. You can either follow, get out of the way, and suffer the consequences if you don't want to follow our program. I have a great example of that. We do have this quest to really understand the effectiveness and what makes these programs effective, and that's really hard to root out, but we're working on that. We'll talk about it. And then I already told you about our actuarial monitoring. So how have we designed our program? It's very much a value and principles-based program, which means it's the company's values, it's patient values, and physician values, and we put those all in the mix together to come up with a process that is unique to Stanford. So you can learn some things from us, but remember that it is a very much a Stanford process. It is designed to promote transparency, integrity, fairness, and of course healing for our patients, our physicians, and our nurses. We do not abandon any fiduciary principles. So, ultimately we run two captive insurance companies and we run a business. And so you cannot not have that frame of mind. You must manage the fiduciary responsibility to the company and balance that with what you do for patients on the other side. Our program very much distinguishes between unanticipated outcomes and preventable unanticipated outcomes. We only pay out on preventable unanticipated outcomes, i.e. medical error. Otherwise, we take a very hard line, very much like the University of Michigan philosophies. Actually, our philosophies are no different than the University of Michigan. Here are some of the mechanics of our program. We have risk and claim advisors, Pearl advisors available to our staff 24/7. We don't educate our staff on disclosure. We do just in time. And we let them report just anything. We actually don't want them to distinguish between what's a preventable, unanticipated outcome and something else. We just say, if you have a concerning outcome, call us. And that has been our traditional way until recently we've opened it up to patients. Consultation is provided by trained individuals, my staff, all internal. We have a clinical risk management team. We have a claims team. It's all in-house. We're talking about professionals that are duly credentialed as attorneys, physicians, attorney physicians, and attorney nurses. So they're very well trained to know how to go through this. No matter what the hospital, we can wrap around their disclosure policy, and our hospitals vary in their approaches on disclosure. Doesn't matter because we can wrap around any of that. We do believe in just in time. We don't train ahead of time, but we do a very intensive training on a case-by-case basis when we go through these. Because if you're a clinician, and I was a clinician, you'll be blessed if you only see two or three of these in your lifetime. So you're not ever going to be an expert at the disclosure process, and it's too key to the process to think that training is going to help you and that you're going to be able to pull that down and access it and do it well. So we do just in time. Heavily focused on assessment. And the difference between CARE and PEARL is that we've learned over time that we have collapsed that process into a very, very short window. And the reason for that is we have learned, and we had a little bit of discussion on this at dinner yesterday, you have an opportunity within those first moments. And as days go by, it becomes more frustrating for the patient, and you will tend to lose trust or lose the patient to an attorney. Not that we mind attorneys being involved, we like them being involved, but we don't want them to shut us down. So we've collapsed our process. We have a very vigorous assessment process, and I'll talk about it. So here is basically what we coach to. We do coach that there will be full disclosure, there will be nothing hidden. It is a sequential communication, as Ken pointed out. We talk about what we know, when we know, and we set up expectations. We always circle back and talk about our lessons learned. If we could, the way we phrase it, if we could do things differently, this is what we would do. The point on compensation, we actually never have a direct conversation that uses the M word, money. We talk about their needs. What are your needs? And so that's sort of the framework to help us understand. As Michelle pointed out, many patients don't want anything. And so we actually don't approach a conversation about compensation. We approach a conversation about their needs, and those needs can run the gambit. They can be monetary needs, compensation needs, or it could be other needs, like I need counseling, or I need daycare, or I need a ride to the corner store. Whatever it is, that's where we go. And of course, active listening is part of the process. We actually use simulation for the folks involved in disclosure, and we monitor, and I'll show you this, we monitor how well they do with the patient and family counsel in their skills in communicating the needs assessment and listening to the patient and really winding them into the process. Our program is simple. There are 5 do's and 3 don'ts, and this is what we teach on to all of our practitioners, our nurses, and our administrators. The first thing we talk about is stabilize the patient. Boy, that seems really basic, doesn't it? But in fact, they do need to be reminded to stabilize the patient, because in a significant event, all kinds of crazy emotional response happens, and you sometimes forget about the patient. It's always about the patient first. The second step we find necessary to actually caution on, we had a case in our OR, very interesting case, closed case, 2 of them actually, same mechanism of injury, occurred 1/2 hour after each other. So what happened is it was a classical system error. It was a ointment that's placed in the eye. It was labeled the same as a different substance. Nurse reached for the different substance, put it in the eye, blinded that patient. That accident went on to be repeated a 1/2 hour later. What's very interesting in this is that the cases, one followed a pearl track, one followed a non-pearl track. What a great example of what happens. Pearl track, extremely healthy communications, emerged from it, trust, paid less. The other track, with the traditional track, went into the full claim, stress for the patient, stress for the physician, and we paid about 40% more than we paid for the Pearl case. Great case, and not scientific by no means, but an interesting example. We do ask our insureds to come to us within 4 hours. We do want to be careful about what we put in the medical record. So we're very upfront that we'd like to have the call no matter what time of the day, and we want to proceed through this carefully in this just-in-time kind of way we do things. We do document in the medical record, but only in relation to the patient's care, not in relation to anything else. It's a sort of a principle in risk management. And then finally, we ask that all communications are coordinated only through the advisor. So our insureds actually have to connect with us and nobody else, and the reason we do that is we do attach a legal privilege to all of this work. One of the first things we do within 1 hour of notification is we have contacted legal counsel and we get an attorney-client privilege. These are the 3 things that we tell them not to do. Don't jump to conclusions. They always do it. It's just a human response. Oh, it's this because you really want to make that patient feel better. Resist that at all costs. We really have a hard time with that. Second principle, do not blame others. Another natural tendency, either to blame folks internally. Oh, well, it was the nurse or another institution or another physician. This was a case that we just recently had with our practicing physicians across the street at a community clinic. That benefits no one. And then finally, we have to remind folks, don't make promises that you can't keep. Once you make these promises, then we have to make a commitment to them. Otherwise, you completely lose trust. So those are 3 no's. Very simple program. We use a 7-day process. So that sounds like a really quick process, doesn't it? Well, it is. Actually, the folks that run this, they have no hair. And they beat me up on this constantly. We used to have a process very much like CARE, which was a little more extended. And over time, we've really collapsed that. It's all encapsulated in this, which is in your packet. You don't need to open it up now. It's very detailed. I would just say that this process is entirely possible, but it is resource intensive. So unlike what Ken said, we built up in our claims unit the capacity to handle this kind of thing. We have 200 claims, more or less, that come into the medical center, into the Summit, which is our insurance company, per year. And we've moved the cases from claims, so our claim numbers have dropped significantly, but that inventory now has moved into a Pearl inventory, and that requires a lot of work. So this is resource intensive for us anyway. So these steps are all outlined on your handout. I just want to tell you that there's different things. Like CARE, there's sort of this first initial assessment. Is this a Pearl or not? What gets in through the floodgate? That's what this first part is. What we've done along the left side here is we've infused the patient experience throughout, because these programs tend to be thought of, the mindset is this is our approach, and we're going to hoist this process on you. And it's a very different thing from a patient perspective. And how do we get so savvy on this? We actually have hired one of our very devastated parents who went through the Pearl process, and she provides a patient advocacy model for us and infuses that patient experience at every step of the way. This is something that we've evolved to. So at each stage as we go through this, we are very cognizant of the patient and what the patient's needs are. And also wound into this is what our physicians are going through. They just go through a different separate track for what we call physician wellness and clinical wellness. So this is the investigatory process, very much like what Ken talked about. I'll leave that. What we do is in 3 days, I ask for a wet read on the situation so that I know where we're going. By 7 days, it's my hope that we actually get to the bottom of things. We know it's not always that simple. Some cases require extensive investigation. You may have to send equipment out for forensic evaluation. You might be waiting for autopsy. You might be waiting for tissue samples, drug testing, et cetera, et cetera. So it's not always possible, but certainly within 90 days, we're trying to figure things out and get to resolution. So our cases are compacted, and we're studying the effect of this right now. So how do we approach a needs assessment? So when we pop that question, what your needs are, what if they come back and say, well, we need $2 million, okay? And they do say that, right? I actually had one that wanted a car and was very specific about the car that they wanted. It was a Ferrari. So I was like, okay, that's an interesting start. So what we do is we start with the needs assessment, and then we quickly move to the valuation. What we do at Stanford is a very careful, thoughtful approach to coming up with the actual dollars that we will put around a Pearl case. We use something called DART, which is short for Decision Analysis Reserve Targeting. Simply stated, it's decision analysis to come up with that dollar amount. The traditional method is to look at what verdicts go for in a jurisdiction, maybe come up with a range, and you're somewhere in that. Our process is a little different in that it incorporates some of that subjectivity, but it moves towards the objective through using Bayesian statistics, Bayesian theory, and I'll show you what that looks like. We always require a settlement authorization from our insureds, so we have to bring our insureds along, including our physicians, and we also require a settlement agreement from our patients and families. And if it's a minor, we will go to court and get what's called a minor's compromise in California to make sure that it is fair to the minor, that they're getting a fair settlement. We do a lot of sponsored mediation. So the first phase is to try and get this done internally with the resources that we have. Not all cases, as we know, resolve at that level. Maybe about 75% of our Pearl cases resolve on our own efforts. And the bulk of those, there's no payment made out. There are cases that are much more challenging and difficult. We will sponsor mediation. Sponsor mediation just means we pay for it. Almost all of our cases, so 99% of our cases, resolve at this stage. There are probably 1 to 2 cases, like the University of Michigan experience, where you don't resolve and it goes on to trial. Of those cases that go on, 100% of them are defense verdicts. So we have a reputation in the community that you better play well with us. If you want to go to trial, you risk everything. That's an all or nothing proposition for them. So this is DART. DART looks like that. And this is how we come up with a valuation. It's a complicated process in that we have a PhD black belt that leads us through the modeling. This is sort of a simple example. This is very important for us. We'll publish on this probably in about a year. We're collecting data. So the idea here is to come up with a range of possibilities so that it will guide what we'll do on in a compensatory manner with any Pearl case and even a litigated case. They should all fall within these ranges. This is just for example. Anyway, this data means nothing because we haven't collected the data and are not ready to display it. But the idea is that we come within a scientific range of possibility on compensation, so it's not too high, not too low, but just right. So here we are with the Pearl enhancements. This is probably where we want to spend the majority of our time. So in the early go, we've looked at Pearl and we've kept our board informed, and we do actuarial monitoring from year to year, and things are going well. We'll see the data in a minute. We decided this past year that it's time for prime time, which means we were going to go live with our patients. And so we've done 4 things. We've developed a patient website. We have a patient video. We have a very simple assessment that will triage patients either into the Pearl program or into the patient relations program, 2 tracks. 1 track, we want to see them because we believe that they have an unanticipated outcome that we should deal with. If someone, for some reason, kind of gets into the system and it wants to complain about the color of the Jell-O, that will go to the patient relations so that my staff is, it's a weird example, but you know what I'm talking about, right? And then we have a brochure for them. This is very, very bold stuff. The other thing that we've done is we've rethought completely our communication model. So we've assessed each and every Pearl case that we do. And one of the things that we have found, despite some really great people, and I'll show you a video of one person, a patient that's involved in one of these situations has a number of issues that they're going through. And we're setting ourselves up for failure. We believe, this is our opinion, we're setting ourselves up for failure by thinking that my claims people or my risk managers are going to be able to front with a patient and instantly have that trust. So we have inserted in the middle of the communications between the folks that manage these cases, risk manager or a claims person, and the patient or family, a patient advocate. And our patient advocate is a very special person. She lost her son to a medical error, just a terrible error that is unimaginable, and she actually talks about it, so I can talk about it. It's a closed case. Leilani was in our children's hospital, and was in the middle of the night, and classic example of a system error. Nurse left practice after this. The alarm was going off at the bedside. The patient, young child, was on a monitor to monitor respirations and heart rate. The nurse, thinking that she was doing the patient a favor and it had no consequences on safety, turned the alarm off in the room. Her mind was, turning the alarm off in the room doesn't do anything to the alarm out by the nurses, and they actually carry a pager as well that alerts them to a drop in respirations or heart rate. Unfortunately, that thinking was wrong, deadly wrong. In fact, when she turned the alarm off, it completely turned the alarm off at the station on her side, and the patient drifted off and died. The next thing we know, mom wakes up, tries to wake up the child is dead. She went through the Pearl process. She's taught us a lot about the Pearl process. She speaks, she writes on this. She is the #1 advocate for patients, and so she has brought something very special to our program that we could never have in a sort of a traditional way of managing claims. So we've really revolved around here. I want to show you a little bit. I go to, what, 11:15, is that right? So we have time. I'm going to show you this a little bit, just so you can get an example of how forward we are with patients. This resides on our public website. You can actually go in there today, pull this down. You can go to any of our hospitals or clinics, pull this down. If you think you had an issue at the hospital, this quickly, within 2 minutes, will inform you of the next steps. Hopefully it works. Okay. This is our website, by the way. So you can see the categories here. This is the one that sits for the Stanford Hospital. It's pulled from guest services, so patients would go to patient representation. It very quickly just says, what is Pearl? Why would you want to be here? There's this video which I'll show you. At the very bottom here, you can actually pull down. You can actually enter the process by just clicking on the button, answering a few questions. Doesn't collect any real significant information, but gets the process going, and it diverts it into those 2 pathways. So many of the things that come in go right to patient relations because they're improper to bog down my claims staff. But we do get direct referrals. Why are we doing this, by the way? Our data says that we do a horrendous job at actually identifying these events. The clinical team, they're oblivious to them. What we might think is concerning and what a patient thinks is concerning are entirely 2 different things. And this is why we've gone to this space. So you can also pull in this brochure. And this is Leilani, and this is the message that we use externally.
Hi, I'm Leilani Schweitzer. I'm the patient liaison for Pearl and a parent who's gone through the Pearl process.
PEARL stands for the Process for Early Assessment and Resolution of Loss. There are benefits and risks for every medical procedure. And even with the best of medical care, rare complications and unanticipated outcomes sometimes happen.
Pearl helps bring understanding. After my son died, I was confused and I was sad and I was angry. My whole world had been turned upside down. Nothing made sense to me. I didn't understand what had happened to him. Pearl answered my questions.
PEARL is designed to address significant, unanticipated, or adverse medical outcomes. You may have a concern about your care, or you may even feel your care caused more medical problems and wonder if it could have been prevented. This is why we created PEARL, to help our patients and their families when these kinds of concerns or events occur. PEARL allows us to better understand what has happened in a patient's care, and if preventable, to keep it from happening in the future. The PEARL process is based on communication, transparency, and integrity.
I always felt that I was being dealt with compassionately. My questions and concerns were never being avoided. I was given honest answers, even when those answers were probably really hard to give me. I know Pearl can help people. I know it heals, and I'm proud to be involved in it.
How does PEARL work? PEARL begins with an in-depth assessment of your concern. We work to thoroughly understand the facts of your care and to communicate them to you. Your questions will be addressed confidentially and fairly. Most complications and unanticipated outcomes are not preventable, but in the unusual event that the outcome of your care is determined to be preventable, steps will be taken to help you and your family recover and heal.
If a patient has concerns about their health care, I encourage them to find out about Pearl. Educate themselves, learn about it, see if it's something that could help them.
There are several ways you can learn more about Pearl. You can visit the Pearl page on either the Guest Services or Patient Relations websites. Here you will find more details about Pearl, including a link to complete a short information form which will allow us to contact you to discuss your concern. You can also call and speak with a Guest Services or Patient Relations team member about Pearl. And we encourage you to discuss your care concerns with your doctor or care team. It is important to note that not every medical outcome will require a Pearl assessment, but every concern will receive a timely and thorough response.
Pearl brings accountability and responsibility, and it brings healing. I know that it helps people, and I'm proud of the fact that my experiences can help other people as well.
We know that our patients' experiences stay with them long after their care has ended. Our goal is to help you find the answers you need. Thank you for entrusting your care to our outstanding care teams at Stanford Hospital and Clinics and Lucille Packard Children's Hospital.
So you can see a very tender message, right? Bold.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University.
That is a required message. Sorry. So a very tender message, tender in the approach with our patients, but you can see you want to be very careful. Every word in this counts. And you have to convince counsel, you have to convince yourself, you have to convince your board to move into this bold space. It's very advanced thinking. Of course, we do a different kind of education with our physicians, and I know many of you are at this space right now. We do a video on the physician and clinical side. Has a very different feel and message. No time to play that. If you want to see that, just contact me, and I can actually get you a link to see that video privately. So the next thing that we've been doing is understanding that every conversation must be carefully constructed. We have examples in the process itself, whether it's a care conversation or a Pearl conversation, of failed communications. And so what we have done is we've put together a simulation program, and I'm going to show you what a video looks like. We started this last year. We had the assistance of David Gaba from the Simulation Center at Stanford, as well as Tom Gallagher helped us with this project. We'll be writing up our results soon. But the bottom line is every word is judged by a patient when they're hearing it in real time. So we have devised a way to, devised a way to capture that moment-to-moment view of the real-time conversations that are occurring in a disclosure and offer communication. So I'll show you an example of what this looks like and how we go about doing it. This is Dr. Dana Welly. She's a OB/GYN and also a risk manager and Pearl advisor. We start off at level 50. We give our patient counsel by toggle switch.
Thank you.
They start at 50. They get warm and fuzzy feelings.
Thank you so much for agreeing to meet with me
They feel
today.
cold.
It's Dana Welly. I work with the risk management
It's
department
fuzzy.
here.
Down
And
is
we
bad
work
things.
with the care team to whenever there's been an unexpected outcome, to help investigate that outcome, not just from a care standpoint, but also using other eyes to look at the problem. And we also try and help the families understand what happened with that outcome. And I really appreciate you taking the time to meet with me today and discuss what happened with your husband.
I am right now. I'm so confused. I'm so devastated, and I have all the emotions
Sure.
that you could think of, and just at loss. I don't know what happened. You know, my life as normal as has ended. You know, my husband's in ICU.
in a Zoom
it's been
attack.
years since I worked, so that's going to be
Look how she's
a
built
huge
trust.
transition for me.
So she's a great example. She
you know,
actually
the
goes off the
bills,
chart.
we have certain
and winds
type
up
of lifestyle
very
that has to
positive
change.
space.
Sure.
And we probably have to have some nursing around.
Turn this off. Okay. So I actually have others that go through this process, and their line goes down. And this is the one thing that we've learned in this process. It really matters who you put in front of the patient. We thought we had the right people. So early on, I told you we assessed our failures. One of our big failures is we had this grandpa of a chief of staff that everybody, he was beloved in the hospital. He went into one of these conversations and he completely blew it. It was so bad, so outrageous that we had a difficult time actually handling the litigation because it got wrapped into the litigation. Extremes. Dana's one extreme and chief of staff was another extreme. So every word makes a difference. Who you put in front of the patient makes a difference. And in our model now, it's that patient advocate. And she goes through the process, the simulation process, on a just-in-time basis. So here we go. This is what we are able to release at this point. This is the things that we're monitoring, and when the time is right and we have enough cases, we will have hard data and some conclusions that we can draw. I like to say it's 15 plus 1. These are the kinds of things that we're capturing. What is the plus 1? You can get lost in this data. So for example, yesterday at dinner we were having this conversation about the number of claims going up. And that can be misleading. So there might be a reaction, oh wow, our claims are really going up, they're up 40% or whatever. What we do is the plus 1 is to look at this program overall because it's a balancing test. There's 15 different things going on here. You need to look at the overall results without drawing conclusions too rash or quickly, just based on the number of claims. I personally don't care if the number of claims go up. It's really, to me, about other factors. As a fiduciary to my 2 insurance companies, it's actually about the bottom line. And our bottom line is quite healthy as a result of Pearl, which is why we continue to do it. So here are 4 of the metrics that we put in front of the board and we monitor on a semi-annual basis. First of all, we look at reporting pattern. What we want to happen is for the reporting to be fast. Unfortunately, 1-year lag. That's terrible results. That tells us that we're really bad at actually estimating and judging what's important to patients. We rely on the clinical team to actually make the referral to our office. So you have one problem there. You're presuming that they're actually going to make that contact. They don't always. And then the second problem is they may not perceive something wrong. So in their mind, in the clinical mind, there's nothing wrong here. But in the patient mind, it's a much different story. So the reason we now have this patient portal is really for the reason of this first item. Frequency. You want your frequency to be lower of legal claims. Now let me define what a claim is. In California, it's easy for us to know what a claim is. It's a 90-day notice or an actual lawsuit that's filed. That's what we're measuring here, not the number of cases that go through Pearl, which are also considered claims. We divide the world this way. So what's happened is our claims volume has gone down because it's now being transferred into the Pearl process. And I think as Michelle pointed out, actually in Pearl itself, at least 95% of those cases close with no payment made. We work them up, a lot of work involved in that. But really the beautiful thing that has happened is because of Pearl, we have less claims being filed, actual legal claims being filed, and less legal claims means what? Less dollars spent. And in fact, 38% reduction in costs over the last 5 years. Year over year, and then we plug those savings back into the organization. We're talking about multi-millions of dollars that has been saved since Pearl began. Can we isolate that to just Pearl? The answer is no. There are other risk management things going on, of course. We have risk management processes that we've fortified. We have things going on with the medical staff, et cetera. But nonetheless, Pearl is a part of this overall program. Closing pattern. We really like closing pattern to be faster. Why? Because our actuaries will tell us the faster you close the claims, the less expensive they will be. And there's data, our own data, to support that. Right now we are sitting at an inconclusive pattern, which we've been for a while. And then the last thing is severity. Would you expect to see severity decrease in a program like Pearl or CARE? And I think we're sort of waiting, meaning Pearl and Stanford is waiting to see whether or not there is a reduction in severity. Right now, we're saying it's inconclusive, and the reason for that is we actually did not, our frame of mind is to settle cases within the DART range that I showed you. That DART range is developed for litigated matters or claims or Pearl cases. It doesn't matter to us. It's the same number. In our mind, we actually never really want to save dollars there. You may save dollars because you may have a patient who doesn't really want to go very far. In this process of openness and trust, you have very good positive feelings, and patients may ask for less. So over time, we may find severity is going down, but it's too soon to say for us, and it's not our goal anyway. So what have we learned? When it's all said and done, prompt evaluation of these patient concerns is very important, and intervention and the way you go about the intervention is very important. Education and training and getting everybody on board, like you're all doing, is critical to success. That is a process that takes years in the making, and then it's a continuous process after that. And maybe during the Q&A we can talk about specifics. Information is power, not only to the insurance company, but also to our clinicians and to the patients. And we believe in full and open, transparent communications. And then finally, it does pay dividends. So we have seen the results. We continue to study the results. So it's all coming together for us, and it makes sense. So we all know about sort of a wrinkle that came in. CMS has a requirement that if you make a payment, it is reported to the Center for Medicare. And how does this affect these programs? Underlying responsibility to reimburse the federal or state government for these types of matters has always been the same. It's just now more articulate. The government requires a report from the insurer, and we make those reports. Our process at Stanford, and you may think about doing this or not, we put it actually into our settlement agreement. So we actually, in our DART process, will be thinking about liens and whether we might be responsible for some part of that lien or not. Generally, at Stanford, we're writing off everything if we see something that could have been done differently. So you shouldn't have a lien situation. But we have had cases where there is a lien because the care was received elsewhere or something else is going on. It does complicate things, and you can expect, the bottom line is, you can really expect to put more money up front if you have one of these situations. But they're not impossible to get through. So it doesn't really, you shouldn't think of this as prohibitive to moving forward a program such as the one you're contemplating. So you can stay current on our program by going to our public website. We post a lot of this information directly for the public. And sort of the things that we're thinking about next is moving this outside of Stanford into our partner institutions. So I want to leave you with a final story. It's a public story. We have a tale of two physicians, one who was insured by Summit, who follows this Pearl approach. Summit is the captive insurance company for Stanford. And literally right across the street was another physician who was insured in a more traditional way that had not adopted the approach that we're discussing here today. This is within the last 6 months. We got into that situation. One of the don'ts is what? Don't point fingers. Well, what did happen is the two physicians started pointing fingers, just in rapid fashion. We followed DART and Pearl. We made a decision that this was a case to be settled. We saw that the event was preventable. We saw causation, we saw damages, and we worked from the very beginning to resolve this case. Although it didn't resolve at our level or in mediation and then went to trial, it paid us dividends because what happened, literally on the courthouse stairs, Stanford settled out on that case. And while it's a confidential settlement and I can't disclose that, you can imagine that if we settle a case in our process, it was in that DART range. So it was exactly where we expected it to be. Unlike the experience of the more traditional approach across the street, they went on to trial with great confidence, and they wanted to blame Stanford as the empty chair for everything, and they were slapped with a $23 million verdict, which in my area, which is Santa Clara, is almost unheard of. So, it's a great example of sort of where we got to go next.